Good evening, everyone, and welcome to today's session. Pediatrics, every day evening, 6 p.m. to 7:30. Mark in your calendar until the NEET PG exam. So we started this crash course from December 13th, and every day we take garma garam 50 to 60 questions and do a discussion. On Saturday, Sunday, we will take 100 questions. So that way, every week we finish one subject. Additionally, please subscribe to our crash course program where you get 427 hours of HD video containing 1500 video lectures covering all the 957 topics for the PG medical entrance, and 10,000 PowerPoint slides of notes, 30 full-scale grand tests, and also 10,000 MCQs as a quiz tournament on the Incus app. All this for a throwaway price of 10,000 bucks. So please take every opportunity. So videos and notes is not enough. You need Dr. Murali Bharadwaz to be with you every day, holding your hand, studying along with you, to inspire you to finish the subjects, topic after topic. That is most important. So I'm very glad to see you all being part of this crash course program and the live broadcast every day evening 6 o'clock. So let's make the great beginning of today. And yes. So those who missed our earlier sessions, please don't forget, I have not removed the videos. You still have them on the YouTube. Yes. A malignant tumor of the childhood that metastasizes to the bones. Most often, bony metastasis is the second nature of neuroblastoma, is what you have to emphatically remember. Good to see Siddhaya, Shailaja, Khan, Artika, Mahendran, and Salunke, Barry Allen, and many more who are all online. Very good. Now, doctor, the process underlying the differences in the expression of a gene according to the which parent has transmitted, whether if the mother is giving you that gene or allele of the gene you are expressing, but not if it is father, or if the father only, if you get that allele, you will express. What is that called as? That is called the anticipation. Whenever, good to see Nipun Galhotra. Hi sir, joining your class after almost 1 year. I joined DSP Pharmacovigilance with your blessings. Absolutely. Thank you so much, Nipun, for coming back. I'm really humbled. A child has got a small head, minor anomalies of the face, including a thin upper lip, growth delay, developmental instability. With all this, what is the possibility? It can be a chromosomal syndrome. It can be a teratogenic syndrome is possible. And yeah, but it cannot be a polygenic syndrome, because you have conditions like hypertension, diabetes. They're all polygenic inheritance kind of syndromes, is what you need to remember. An affected male infant born to the normal parents could be example of what? The kid is affected, but the parents are normal. It's possible in an autosomal recessive polygenic disorder or a vertically transmitted disorder, but not in autosomal dominant disorder. Why? Because in an autosomal dominant disorder, if a child is affected, means compulsorily that is coming from obviously one of the parent, and that parent definitely will show the disease. It is impossible for the normal parents passing a disease expression in case of autosomal dominant. It is possible in autosomal recessive. That's what you need to appreciate. So an autosomal dominant disorder, if present in the parents, will always express phenotypically. So it is not possible for the normal parents to have a child affected with an autosomal dominant disorder, is what you have to emphatically remember. Keep punching your answers, doctor. Dr. Mondal and many more. Keep punching the answers. And before we start this discussion, I give a small PowerPoint quiz. Every question is rotating within 12 seconds. So try to keep punching your answers. Whatever be your level of preparation, doesn't matter. Right? Now, the father has widely spaced eyes, increased facial hair and deafness. One of the 3 children has deafness and similar facial features. Mother is normal. What is the most likely pattern of inheritance? So father is affected, child is affected, and that's the reason it is autosomal dominant. So quickly, doctor, whether you take pathology, whether you take genetics in anatomy, or whether you take pediatrics, definitely आने वाला question है inheritance patterns. For examiner, inheritance patterns is the favorite topic which you need to remember. Right? So, autosomal dominant. 5 points आपके मुट्ठी में रहना बाबूजी. 5 points. Both the genders are affected, not just only males. The male and female at equal frequency. It does not skip generation. Father को है तो बेटे को आएगा, बेटे को है तो grandbete को आएगा. If 2 parents without autosomal disease have child with an autosomal disease, is there any possibility? Generally, autosomal dominant means if the child is having autosomal dominant, definitely one of the parents should have. But if both the parents are normal, still the child has autosomal dominant, means एक ही possibility हो सकता. Autosomal dominant can show reduced penetrance, variable expressivity. That's a possibility. Then pathology. Most of the time, structural disease like collagen is a structural disease. Spectrin, structural protein. Similarly, ankyrin, structural protein. Structural protein disorders, the genes affecting structural proteins, they're all autosomal dominant. इसलिए Marfan syndrome ले लो, hereditary spherocytosis ले लो, autosomal dominant होता है. Presentation usually after the birth, after the puberty, and is often pleiotropic. That is, a single genetic defect will affect several organ systems. That is the nature of autosomal dominant, is what you need to remember. समझ में आ गए ना? आपके 100 pages किताब में ये सब points चल रहा है. Last moment before exam, you have to do a revision, right, doctor? So it doesn't matter मैं जाके वो super duper entrance coaching में गया या some national teacher taught me. कुछ भी फर्क नहीं पड़ता। ये सब चीजें आपके मन में समझ में आना चाहिए। Some students are very good in just reading and then remembering. For them, entrance coaching, bleaching, all that doesn't work. Some students, we are all growing through our learning process, right? सुने तो समझ सकते, पढ़े तो एक वर्ड भी नहीं समझ सकते. So each of us will grow with certain learning assets and learning defects. So we should realize what works for us. Just because our roommate became a topper in entrance by going to some national faculty coaching program, there is no guarantee that it applies to us. Just because one of our friends has watched some video lectures, it may not apply for us. So what applies for us, we need to be very sure about. But one thing I am very sure, Doctor, I am very much applicable for a large number of students in this past 22 years of my teaching, almost 2 lakh students, because I myself is not a very good student. Bad students like us become good teachers, coincidentally, because we know what applies, what doesn't apply to the mind of most of the students. So, Doctor, next 90 days, you have wonderful time, Doctor. अभी शुरू करें तो भी आप नीट पीजी में टॉपर बन सकते हो. Only thing is, every day 6 p.m. evening, don't forget to switch on to YouTube, like Akashwani Panchrangi Karikram. So, pleiotropic, several organ systems involved with single genetic disorder is the nature of the autosomal dominant. So, quickly give me some classical examples, Doctor. Von Willebrand disease, Huntington's disease, osteogenesis imperfecta, achondroplasia, Marfan syndrome, neurofibromatosis type 1, and acute intermittent porphyria, autosomal dominant. Most commonly asked MCQ in the NEET PG exam. So this is the typical pedigree, Dr. Sir. Every time they ask in the entrance exam, you have to be very sure. So what did you see? How do you recognize that this is autosomal dominant? दादाजी को हो गया, दादू को भी हो गया, और अम्मी को, पापा को हो गया, और even the next generation. No skipping of generations. No skipping of generations. That is an important clue. Both boys and girls are equally affected. That is the clue number 2. Male is to female is equal to 1:1. Barabar? And whenever anyone is affected, invariably they are born to someone, one of the parent definitely is an affected parent. So these are the clues to say this pedigree is autosomal dominant. कल के नीट पीजी में इमेज बेस्ड MCQ यही क्वेश्चन आएगा और आप याद रखिएगा. डॉक्टर मुरली भारद्वाज in this wonderful evening. The affected child must receive the disease from an affected parent. So a homozygote dominant parent has 100% of having an affected child. And 2 heterozygote parents with the autosomal dominant disease, they have 75% chances of having a child with disease phenotype. So somebody has capital A, small a, capital A, small a. What are the possibilities? There can be AA, there can be capital A, small a, there can be small a, capital A, there can be small a, small a. Only this person will not have disease. Otherwise, all these are autosomal dominant and they become diseased. So 3 out of 4 get disease. So 75% chance of having the disease phenotype. If 2 heterozygote parents with autosomal dominant happen to marry each other when they met in medical college, इनको भी गोल्ड मेडल्स आ रहे, इनको भी गोल्ड मेडल्स आ रहे, ये दोनों मिलके 4 बच्चों को पैदा किए, तो अगर गोल्ड मेडल आना ऑटोसोमल डोमिनेंट ट्रेट है तो 3 out of 4 will get gold medal and 1 child will not even pass LKG also, right? So be very sure. Autosomal recessive. Autosomal recessive. Typically, 1/4 of the offspring affected when both the parents are carriers. Half of the offspring are carriers when both parents are carriers. 2/3 of the non-affected children are carriers. So, अगर आप AA लेके, if you happen to make a chart, you can understand these 3 points. So please try to take a pen and paper and play with this pedigree charts and percentages before you go to exam. So there can be skipping of generation. A generation में नहीं हुआ पहले वाला, second generation में एक है, next generation में नहीं है. So that's how. And consanguinity. Nobody in the medical college accepted when you said I love you. So you are very depressed. बैठ के पढ़ रहे हो. Our mama's daughter came and said, hey, young handsome guy, maybe I can consider you. So consanguineous marriage हो गया, right? Now, what is the pathology? Most of the times, autosomal recessive occur rate limiting enzymes controlling genes are affected in autosomal recessive. Autosomal recessive present in the infancy, they don't wait until adulthood, unlike autosomal dominant. They are more severe, they are more lethal, and they need to have 2 defective copies of the gene. And any consanguinity definitely will bring those 2 copies required for the autosomal recessive to become expressive. So cystic fibrosis, inbornness of metabolism, phenylketonuria, one guy, Pompe, glycogen storage diseases, all sphingolipidosis are autosomal recessive except Fabry. All mucopolysaccharidosis are autosomal recessive except Hunter. So Hurler is autosomal recessive. Autosomal recessive. But Hunter is X-linked. So that is the difference between the 2. So both these things are favorite MCQs of examiner doctor. और एक बार बोलो मेरे साथ, all sphingolipidosis are autosomal recessive except Fabry's, which is X-linked. All mucopolysaccharidosis are autosomal recessive except Hunter, which is X-linked. That is what you should remember. Similarly, sickle cell anemia, thalassemia, albinism, autosomal recessive PKD, hemochromatosis. It is autosomal recessive, is what you need to remember. Now, doctor, comes an interesting story. X-linked recessive का story क्या है? Males must receive the defective gene from the carrier mother. अगर आप हीमोफीलिया हिस्ट्री लिए तो Queen Victoria is called the grandma of entire Europe. So she is responsible for being a carrier for leading to hemophilia spread. She is the great-grandmother of hemophilia among the royal families across Europe. So carriers' mother's sons have 50% of having disease. And the affected males give copy to all their daughters. And skip generations. So male to male transmission is not allowed. That's the reason there is a possibility for skipped generation, just like in autosomal recessive. So the defect is once more in enzymatic genes in case of the X-linked recessive, similar to autosomal recessive. Usually they present at the time of puberty. Then if you look at the females, females generally don't show phenotypic expression. Even if they show, it will be milder compared to that of the affected males. So this is a very important thing you should remember, that how a X-linked recessive typically look like. So every time the affected guys are all boys, that is X-linked recessive. So hemophilia A and B, Lesch-Kanihan syndrome, Duking's muscular dystrophy, Menkes disease, hemophilia A, hemophilia B, red-green color blindness, and ornithine transcarbamylase deficiency. You should not forget. Finally comes X-linked dominant. Bhaiya, this is the favorite question of the examiner. There are only 3 conditions: hypophosphatemic rickets, otherwise called vitamin D resistance rickets. इसका दूसरा नाम है phosphate diabetes, right? Phosphate diabetes, hypophosphatemic rickets, fragile X syndrome, Alport syndrome. You should remember because they are X-linked dominant. And don't forget how to identify X-linked dominant. X-linked dominant में girl भी affect हो सकता, boy भी affect हो सकता, भूलना नहीं, right? So unlike X-linked recessive. Then comes the mitochondrial inheritance. Males and females equal frequency. It does not skip generations. It is only transmitted from the affected female, and it presents with neuropathies, myopathies, because mitochondria, oxidative phosphorylation, and the need for a lot of ATPs very much is there for the nerves and muscles. That's the reason most of the mitochondrial inheritances will show neuropathy and myopathy is what you need to remember. So myoclonic epilepsy with ragged red muscle fiber, MERRF. Leber's hereditary optic neuropathy and MELAS, which is mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes is what you need to remember. So this is a typical example of what you call mitochondrial inheritance. So इसलिए डॉक्टर inheritance algorithm आपको समझ में आना चाहिए. First look if the offspring with the disease has a parent with the disease. If yes, it is dominant. If no, it is recessive. If it is dominant, it does not skip generations. If recessive, it skips generations. Then look whether male to male transmission हो रहा या नहीं. अगर हो रहा तो autosomal dominant, नहीं हो रहा तो X-linked होता है. So then comes, do daughters of the affected male have the disease or not? You look for. If yes, then X-linked dominant. If no, it is mitochondrial. Simple, na? How do you approach? So next time, tomorrow NEET PG में 1 MCQ on pedigree. Without that, there is no question paper. Barabar? So you should remember this emphatically. Now, if it is recessive, it can skip generations. It is predominantly males with disease. If yes, X-linked recessive. If no, it is autosomal recessive. So this inheritance algorithm, how to pin down your diagnosis to X-linked dominant, mitochondrial, autosomal dominant, autosomal recessive, and X-linked recessive, you have to be very sure about, doctor. Did everybody understand? Is there anybody still having confusion? Please raise the hand. Did you understand? Please punch into the chat window, doctor. Otherwise, I'll once more go back into the flashback. So how do you identify inheritance? How do you interpret the pedigree? Can you please punch whether you understood? So first look, does offspring with the disease have a parent with the disease? Always, that is the first thing you look for. So this is an offspring with the disease. Does she have a parent with disease? Yes, sir. Offspring with disease, parent with disease. Offspring with disease, parent with disease. Offspring with disease, parent with disease. Then it is dominant. Then, do daughters of an affected male have disease? So this is an affected male. The daughter is not having disease. So that is the clue to say this is mitochondrial. Barabar, doctor? That's good. I would appreciate if you can punch. Have you understood? We can move forward. Yeah. A baby has recently developed mouthing but has not developed stranger anxiety or likes and dislikes for food. What is the appropriate age? So you should remember, what age does mouthing develop? What age does stranger anxiety develop? You have to be very sure about. So you should know that baby will start reaching and grabbing the things when they are 3 to 5 months. Once they manage to grab it, they will put it to mouth. So mouthing will begin between 3 to 5. So somebody developed mouthing means he is between 3 to 5. But fear for strangers and that anxiety, it develops only at 7 to 10 months of age. And it usually passes away between 18 months and 2 years. So out of all these 4, which milestone develops first is a very important question. So let us look at each of them. Crawling between 6 to 10 months of age. In fact, some kids altogether may drop from crawling. At 6 months of age, babies will rock back and forth on the hands and knees. And by 9 months, babies will typically creep and crawl, is what you need to remember. The older infants, 6 to 18 months, smiles at their own reflection in mirror. A toddler 15 to 36 shows recognition of self while looking in mirror and touching the nose. So appreciating in the front of the mirror is very important landmark. Then comes pincer grasp. A baby typically develops this between 9 and 10. So pincer grasp is very important for a neuropediatrician because to hold a pincer grasp, your mind and your muscles must have a coordination. Your cerebral cortex, motor area, and the muscles. A 6-year-old child has IQ of 50. That means he is as old as 3 years old. So identifying colors, reading a sentence, riding a bicycle, copying a triangle, each of them, what is the age at which they develop is the favorite question of the examiner. So you have to be very sure, doctor. This is the most important PPT slide you should remember. Take a photo, screenshot. Vertical line. At the age 2, he imitates. At the age 3, he copies and masters. Horizontal line. Age 2.5, he imitates. Age 3, he copies and masters. Circle shape. By age 3, he masters. Cross shape. Age 4, he copies. Square by age 4. right or left diagonals, age 4.5. And by age 5, he can make an X shape and triangle shape by age 5. शॉर्ट आने वाला क्वेश्चन है पीडियाट्रिक्स में, बराबर डॉक्टर. So every day your confidence levels should keep on rising, doctor. Keep on rising. That is most important thing. Many times when I remember those days when I myself was a student like all of you preparing for entrance, to study all these things alone is a boring job. So एक साथी साथ में है तो रोज उनके साथ पढ़ाई कर रहे तो you will be able to pass through this journey called NEET PG very easily. Don't forget, Murali Bharadwaz is that friend of you who will be your classmate, roommate, reading roommate, benchmate to study with you every day until the day of exam and hold your hand and take you to the exam hall. And when a good teacher and a tough student work together, the only outcome will be the success. So be very sure about it. So generally children identify the colors by 18 months. They name different colors. Naming is different, recognizing is different, doctor. By the age of 2.5 to 3 years. Now there are some bike riding milestones which you need to remember. Push the bike, 18 months. Tricycle, 3 years. Two-wheeled bike with training wheels, 4 years. Two-wheeled bikes without training wheels, 5 years. Three-wheel scooter, 4 years. Two-wheel scooter, 5 years. That is what you need to remember. When will morose reflex disappear? By 3 months. Asymmetrical tonic reflex, morose reflex, crossed extensor reflex, they're all the primitive reflexes which are present at birth. Not symmetric tonic reflex, tonic neck reflex. So asymmetric tonic neck typically will be born there at birth, and it will, if at all it continues beyond 6 months, it means there's a problem in the upper motor neurons. Symmetric tonic reflex जो होता है, it starts between 6 to 9 months old. That's the point. What is the best indicator of a long-term nutritional status? It is the height for age. Height is an indicator of how long you had been malnourished. What are the most common tumor in the children? Leukemia. Now there are certain pre-leukemic genetic disorders that you need to remember. Patau syndrome, Klinefelter syndrome, Down syndrome, they're all predisposing for AML. Good and bad prognostic, good and bad prognostic for the ALL. Favorite MCQ of entrance. Every time you go for the AIMS entrance exam, invariably one question will come on this. So first, so ये तो purely बट्टी मारने का मैटर है डॉक्टर, completely बट्टी मारने का आइटम है. WBC count less than 10,000 favorable, 2 to 10 years favorable, less than 1 year, more than 10 years unfavorable. Female is favorable, white is favorable. But splenomegaly, hepatomegaly, lymphadenopathy, when it is massive, it is unfavorable. Testicular enlargement, unfavorable. CNS involvement, unfavorable. FAB type L2, unfavorable. T1221, tell AML1, trisomy is 4, 10, 17. 3 numbers you need to remember. Favorable. इसके लिए कुछ दिमाग का जरूरत है क्या? इसके लिए जीनियस होने का जरूरत है क्या? बट्टी मारना, right? T922, T411, MLL, AF4 unfavorable. Hyperploidy is favorable. Time for remission less than 14 days is favorable. मेरे प्यारे भारतवासियों, prognostic factors of ALL गर्मा-गर्म बाई हार्ट करके एंट्रेंस को जाना डेफिनेटली पूछने वाला क्वेश्चन है. Now what are the modified Jones criteria? So you should remember carditis, polyarthritis, chorea, erythematous, erythema marginatum, subcutaneous nodules, they're all major. Whereas the fever, polyarthralgia, elevated ESR, C-reactive protein, prolonged PR interval, they're all minor, is what you should remember. Pathology of fallow में ASD, additionally ASD data. Cardiomyopathy is a feature of POMP, Friedreich's ataxia, and also Duchenne's muscular dystrophy. Whereas Lowe's syndrome, it is excellent to receive first of all. मोहब्बत अंधा होता है. Love is excellent today, right? So they will have congenital cataract, अंधा होता है. Hypotonia, areflexia, proximal tubular acidosis, amino aciduria, phosphaturia, low molecular weight proteinuria, intellectual disability. They are all the features of the Lowe syndrome, is what you need to remember. So what is the enzyme which become deficient in Lowe? Inositol polyphosphate 5-phosphatase enzyme is the one. OCRL1 gene is another thing you need to remember for Lowe's. So how do you treat asthma? Acute asthma may, there is nothing more effective than a short-acting beta-2 agonist. SABA is the treatment. Gefileucast is the leukotriene receptor antagonist. Then a child with 3-day history of upper respiratory infection has stridor, and that decreases on lying down position. Very important clue to say it is CRU, which is laryngotracheobronchitis. Steeple sign. You remember ना? Radiology में X-ray लिए तो steeple sign is what you typically come across. A newborn has congenital heart failure. Congenital heart failure, okay? He has a bulging anther fontanelle with a bruit on auscultation, hypoechoic midline mass with dilated lateral ventricles. Classical. Vein of Galen malformation. So this is a typical vein of Galen's malformation, doctor. Favorite clinical vignette in the NEET PG exam. Meningitis depending upon the age. If you missed the yesterday's lecture, so please take every opportunity. Streptococcus pneumonia. Jitteriness versus seizures. A lot of times as doctors, we are very much worried whenever our own child becomes sick, you know. We start remembering so many things, doubts will come in our mind. Is my child having seizures? Oh my God, etc., etc. So be very sure. Being a doctor and being a parent is the toughest thing, job, doctor. But luckily, our pediatrician classmates will be there. No, they will tell, hey, come on, he's a normal kid. So, how do you differentiate seizures from jitteriness in the case of the children? If you stimulate, jitteriness can appear. Jitteriness can appear. If you passively do flexion, jitteriness will disappear. Autonomic phenomena are present only in seizures, not in jitteriness. Eye and facial movements only in seizures. And the rate of the movement is identical in either direction. Whereas seizures, clonic seizures show rapid alteration of fast and slow phase of movements. And EEG will show abnormality if it is a seizure but not jitteriness. Will you remember? This is the favorite NEET PG MCQ. Jarur aane wala question hai. A child has microcephaly. A child has microcephaly, blue eyes, fair skin, mental retardation. Oh my God. Even a first year MBBS student will answer it correctly. Ferric chloride test is the clue. Phenylketonuria. Darkening of the urine on standing and ochronosis. Alkatonuria. A premature baby of 34 weeks was delivered and there are bullous lesions, periostitis. Classical feature of the congenital syphilis, so you need to do VDRL for the mother and the baby. There's a drowsiness, decreased DTR, and seizures. And there is a lead line on the gum. There is a constipation. How will you treat that? EDTA is considered to be the management of choice. Cat eye syndrome. Come on. Punch your answers for this question, doctor. Let me check how many of you are not sleepy and very much awake on this wonderful winter evening where you are fighting with all your friends in this battle called NEET PG. Dharma Kshetre, Kurukshetre, NEET PG entrance are ahead. Come on, punch your answers, doctor. Saujanya, Atman, Artika, Arun, Mondal, Nipun, Siddhaya, and many more who are all online. Come on. Punch your answers, doc. Yes. Yeah. So please punch your answers into the chat window. That's how we all can be strongly interactive rather than a passive learning, doctor. Come on, punch your answers. Cat eye syndrome is what? Good. Atik Jilani is proposing partial trisomy of 22. Absolutely. Shailaja is also thinking the same. Very good. So cat's eye syndrome, there is a short arm P and small section of the long arm Q of the chromosome 22 is present trisomic or tetrasomic. So that is cat eye syndrome. So many of the people with the cat eye syndrome can live long and normal lives. Now coming to autosomal dominant inheritance once more. Marfan osteogenesis imperfecta and Ehlers-Danlos. Fabry is excellent. In an autosomal recessive disorder, parent is normal and other carrier and the child is also affected. And the other is a carrier, autosomal recessive disorder. One parent is normal, other is carrier and the child is also affected. What is the reason? If the parent is normal and the other is a carrier, then in an autosomal recessive, all kids must be carriers, but one of them turned out to be expressing the disease. What is the possibility? It is uniparental disomy, which is underlying cause. So whenever a non-disjunction occurs in both the mother and father's gametes, causing two copies of one chromosome to come only from one parent, it is a very rare event, but it can happen. And that can lead to the development of the expression of the disease. That means small a, capital A, small a. Right? So only one parent is having this autosomal recessive gene, but that gene duplicated itself, and directly from that particular parent it came to the kid. So the kid received a duplicated autosomal recessive genes, two alleles from the single parent. And that is the reason, though it is autosomal recessive, the child developed the clinical condition. So that is called uniparental disomy. So both the copies coming from same, and that to the diseased copy is coming. So looking at this, try to find out what is the inheritance pattern. So just before we discussed, this is a classical mitochondrial inheritance, is what you are able to see. Gomes classification, let's talk about it. What is wrong about it? It is based on 50th centile Boston standard. Between 75 to 89 implies mild malnutrition, and it has a prognostic value, especially for the hospitalized children. That is what you need to remember. Gomes. Abhi doctor, jara 10 points. Let us learn 10 points about malnutrition. What are the indicators of PEM? Height for age. Height of the child by height of the normal child of the same age into 100 will give you height for age. So this is an indicator of the stunting, otherwise called chronic malnutrition. Height of the age is a very good indicator. Weight for height. That is weight of a child and the weight of a normal child of the same height. Acute malnutrition. Similarly, weight for age, weight of the child by weight of a normal child of the same age. And mid-arm circumference, this is used for screening. Body mass index, weight in kg divided by square in height in meters. And what is Z score? It is the child's height minus the median height for the age and sex of the child divided by the relevant standard deviation will give you the Z score. So if you look at the Gomes classification, in this the weight is assessed at various ages by a standard weight chart. So first degree means 75 to 90% expected weight, second degree 60 to 75%, third degree is less than 60% of the expected weight is what you need to remember. So the weight for age percentiles, this is how the plotting is done between the age 2 to 20. 2 to 20. Then Harvard classification. Once more, let me tell you, doctor. PSM, Pediatrics, दोनों में malnutrition is the favorite topic. अगर इधर escape हो गया तो उधर पकड़ेगा, उधर escape किए तो इधर पकड़ेगा examiner. So इसलिए एक गर्मा-गर्म master करने का topic है. There is no other go. The child weight, 50th percentile is healthy and is taken as 100%. Between 80 to 100% of 50th percentile is healthy child. Less than 80% is malnourished. 71 to 80% of 50th percentile is grade 1. 61 to 70% of the 50th percentile is grade 2. And less than 50% of the 50th percentile is grade 4, Harvard classification. Then comes the Wellcome's classification. Finally, you will become pediatrician or not, भगवान को मालूम, मगर कुछ magician बनने के लिए ये सब पढ़ना पड़ेगा. So look for weight for age, edema present or absent. 80 to 60% of the standard weight for age with edema quasi-ortho. Without edema, it's called ponderal retardation. less than 60% of standard weight for age. With edema, marasmic quasi-order. If without edema, you call marasmus. So don't forget. Then comes the Waterloo's classification. So it is based on wasting, that is the percentage of the expected weight for height, and the degree of stunting, that is the percentage of the expected height for age. Both of them are given the criteria in Waterloo. So grade 0 means more than 95% stunting, more than 90% wasting. So you try to take a pick of it and somehow sit with your classmates. You have to एक दो मर्तबा रिविजन करके जरा इसको बाय हार्ट करना पड़ेगा. Mid-arm circumference. Mid-upper arm circumference less than 12 centimeter means severe wasting. Skin fold thickness. You will be using a special calipers called Herpenden in the region of the triceps. Normally is 9 to 11, malnourished less than 9. It is an index of body weight is what you should remember. Then comes the Udani classification. You look for the loss of fat. Only in the buttock grade 1, axillary groin grade 2, abdomen, chest and back grade 3, buccal pad of fat. It is grade 4 is what you should remember. Kawasaki index of malnutrition. It is the ratio between the mid-arm circumference to that of the head circumference. And this ratio is constant between 4 months to 4 years of age, irrespective of the sex. And here, mild, moderate, severe depends on the ratio. 0.32 to 0.28 is mild, 0.279 to 0.25 is moderate, less than 0.25. The ratio between MAC to HC is considered to be severe malnutrition. Kawasaki index. Colles classification. The Z scores of the BMI of age. Grade 1 Z score less than -1, 2 is -2, 3 is -3. So this is how the BMI for the age in the boys looks like. Then WHO classification. Once more, you will be looking for edema, weight for height, height by age, accordingly moderate and severe is how you divide. So this is the weight for height for boys, length for height for boys, WHO. So this is the boring story called protein energy malnutrition indicators by hearting things जो आपके मुट्ठी में रहना है. So if any topper says or thinks that because he is the only brilliant guy he became topper, no doctor. Topping the NEET PG entrance more to do with adrenal, willpower, grit. 10 पेज पढ़ लिए तो 5 पेज भूल जाते हैं. और एग्जाम नजदीक आ रहे हैं और ज्यादा भुलावा हो रहा है, more and more dementia. So ability to manage the stress, bring a focus to the preparation, and then in the 3 hours cracking the exam with a good practice before that. That is all what you need. So in this context, doctor, I like to once more show to all of you. Don't forget www.onlinembbs.com. So this is the best place, cheapest place, affordable place to have a focused NEET PG self-preparation. 427 hours of HD videos, almost 1500 videos. You have along with 10,000 PowerPoint slides. So once you come here, you have this 427 hours focused NEET PG prep. So once you click on this, you have 1500 HD videos. Medicine may 39 hours, pharmacology may 50 hours, pathology may 19 hours, like that. So every day 3 to 4 hours of videos khatam kare to your confidence keep growing. So some of the free videos that we have placed, you can always have a preview. So you have all the various topics. So Streptococcus, Staphylococcus, for example. So you can go to the preview. I'm giving you, preview means free. Even for the people who did not subscribe, we provided few sample videos. So there is always a PowerPoint available of whatever that we discuss. यहाँ ऊपर के वीडियो में जो भी डिस्कशन होता है उसका PowerPoint available है, all HD videos. So this gives you a consolidated preparation. So these 427 hours of total 1500 videos, along with 10,000 PowerPoint slides of notes and 30 full-scale grant tests. We have an online mock test available, given as a complement of this package, along with 10,000 MCQs in the form of quiz tournaments on the Incus app, then 150 hours of daily live online interactive class, evening 6 p.m. with Dr. Murali Bharadwaz, all for a small price of 10,000 rupees in this next 4 months. So take every opportunity to subscribe and make the best use to become a topper. The most common cause of the short stature, constitutional growth delay. Yesterday we discussed familial short stature, constitutional growth delay. How do you differentiate between the two? A very low birth weight preterm is on ventilator, on respiratory distress, and has necrotizing enterocolitis with perforation. You have to do peritoneal drainage as the treatment. Probiotics, they are found to have a great role, especially in preterm infants with risk of developing necrotizing enterocolitis. There's a massive hepatomegaly, hypoglycemia, even after giving glucagon, blood glucose not rising. What does it indicate? It simply indicates glucagon injected intravenously in a patient with glycogen storage disease normally rises the blood sugar, even in starving state. But if that response is not coming, then it excludes the possibility of, suppose if sugar response is coming, then it is not likely to be von Geyrk or Cori, because in both of them, glucagon diet, sugar response doesn't come. So glycogen storage disorder 1 is called von Geyrk. In this, there is an enlarged liver, kidneys due to glycogen and lipid storage. There is a retarded growth, low blood sugar, high blood lactate, high lipid, high uric acid, hyperuricemia. So this is a 5-year-old boy with GSD1 with a significant hepatomegaly is what you are able to see. Coarctation of aorta is often associated with PDA. Right-sided aortic arch is commonly associated with truncus arteriosus. PDA, rubella में होता है PDA. Ligation and division of the ductus is the treatment. But if there is hypoxia, immaturity, then it is important to maintain the patency of the PDA. They're all true. A child has severe respiratory distress 2 days after the birth with a scaphoid abdomen. Scaphoid abdomen is a very important clue in this question, doctor, which says that there is a diaphragmatic hernia. So after ET tube placement, the maximal cardiac impulse shifted further to the right side. So what should be done in this given case? You remove the tube and reattempt the intubation. So A 7.5-month-old child with cough, mild stridor on oral antibiotics, hyperlucency, obstructive curve, there is a wheeze, productive cough, mild fever. So all these are the important clues to say bronchiolitis obliterans as the diagnosis. A male born at term after a uncomplicated pregnancy, labor, delivery, uncomplicated. Normal heart shadow, but fine reticulonodular infiltrates radiating from the hilum. And the family history shows a similar clinical course in the death of a male and female sibling at 1 month and 2 months of age. What is your diagnosis? This is the classical clinical vignette repeatedly asked in entrance about neonatal alveolar proteinosis. A little more discussion on this is already there in the online mbbs.com video library. Please take every opportunity to do the revision. 6-year-old recurrent episodes of the gross hematuria for 2 years. Always the most common cause of the recurrent benign hematuria. Benign recurrent hematuria. Every time there is upper respiratory infection, hematuria occurs. That is the history called IgA nephropathy. Kawasaki disease. What is the cause of the death in Kawasaki disease? Kawasaki disease is a vasculitis that can lead to coronary artery aneurysms, is what you need to remember. Now about 21-alpha hydroxylase deficiency. We have discussed about all this congenital adrenal hyperplasias in a great detail, doctor. If I say most common CAH in children, 21-alpha hydroxylase. 21 So yesterday we discussed a mnemonic, doctor. I think you all remember, those who missed the class. A-T. A होता है aldosterone, T होता है testosterone. So you have 21, 11, 17. So 21 में 1. This is 2, this is 1. 1 means elevated. This is 1, 1. So both are elevated. This is 1, 7. So this is aldosterone only elevated. And testosterone is not. So this is how you can remember. So testosterone elevated, but aldosterone is decreased. So that is the reason these patients of 21 will have salt losing, failure to thrive, aldosterone deficiency. Always aldosterone will cause sodium retention, potassium loss into urine, sodium in the blood. That is what aldosterone will do. If aldosterone is not there, potassium in the blood, sodium into the urine. So potassium into the blood means they should have hyperkalemia, not hypokalemia, is what you need to remember. Commonest type of seizures in the newborn are always the subtle seizures. Symptomatic CNS involvement in a neonate commonly is with rubella and herpes simplex virus, is what you need to remember. So that brings us to the end of today's session. So doctor, in this long marathon of almost 1.5 hours, starting at 6 o'clock, we revised a good number of topics, and I hope you are more confident than what you were 1.5 hours before. So that's how every day we should keep picking up a little bit of confidence, and spend another 3 to 4 hours at least with onlinemmbbs.com video library and playing quiz tournaments on the Incus app. Don't forget to download, and you're sure to become the topper when Dr. Murali Bharadwaz is there with you. Thank you very much. Once more, we will all meet up tomorrow at 6 p.m. same time on YouTube. And don't forget to bring your friends. Good night.